In critical care, anticoagulation and thromboprophylaxis are vital for preventing thromboembolic events. Advanced strategies include individualized dosing and monitoring of anticoagulants like heparin and direct oral anticoagulants. Understanding patient-specific factors, such as renal function and bleeding risk, is crucial for optimizing therapy in the intensive care unit. Advanced anticoagulation strategies in the intensive care unit focus on balancing efficacy and safety. Critically ill patients require tailored approaches due to altered pharmacokinetics and increased bleeding risks. Key strategies include individualized dosing, vigilant monitoring, and integrating pharmacologic and mechanical methods to prevent thromboembolic events while minimizing complications. Critically ill patients face unique venous thromboembolism risks, necessitating tailored risk assessments. Pharmacologic and mechanical thromboprophylaxis methods should be compared for efficacy. Selecting appropriate anticoagulants, understanding dosing, and monitoring are crucial. Applying current guidelines ensures optimal anticoagulation practices in the intensive care unit, enhancing patient outcomes. Critically ill patients face heightened venous thromboembolism risk due to factors like prolonged immobility, sepsis, major trauma, active malignancy, and central venous catheters. Complications include deep vein thrombosis, presenting as unilateral leg swelling and pain, and pulmonary embolism, causing acute hypoxemia and chest pain. Effective prevention is crucial to minimize intensive care unit morbidity and mortality. Low molecular weight heparin, like enoxaparin, offers predictable pharmacokinetics and a lower heparin-induced thrombocytopenia risk, but requires renal dose adjustments. Unfractionated heparin is renal safe, with a short half-life and reversibility via protamine. Fondaparinux, with no heparin-induced thrombocytopenia risk, is contraindicated in severe renal failure and has limited reversal options. Adjust dosing for renal dysfunction, hepatic impairment, and obesity. Mechanical prophylaxis methods include intermittent pneumatic compression and graduated compression stockings. Sequential compression devices enhance venous return, reducing stasis, and are most effective with continuous use. Graduated stockings offer pressure gradients, requiring proper sizing and daily skin checks. These methods are crucial for patients contraindicated for pharmacologic therapy due to active bleeding, severe thrombocytopenia, or significant coagulopathy. Therapeutic anticoagulation in the intensive care unit is crucial for patients with atrial fibrillation, mechanical heart valves, or venous thromboembolism. Intravenous unfractionated heparin is ideal for unstable patients due to its rapid action and reversibility. Low molecular weight heparin suits stable patients, offering fixed dosing and lower heparin-induced thrombocytopenia risk. Direct oral anticoagulants have limited intensive care unit use due to contraindications and costly reversal agents. Monitoring anticoagulation in intensive care unit requires precision. For low molecular weight heparin, monitor anti-XA levels in pregnancy, obesity, and renal impairment, targeting 0.3–0.7 international units per milliliter for prophylaxis. Unfractionated heparin monitoring uses activated partial thromboplastin time or anti-XA, aiming for 60 to 80 seconds or 0.3–0.7 international units per milliliter. Safety protocols include daily platelet counts for heparin-induced thrombocytopenia, renal function checks, and bleeding assessments. Be cautious with drug interactions, especially with antiplatelets and nonsteroidal anti-inflammatory drugs. In intensive care unit settings, renal failure requires careful anticoagulant selection. For creatinine clearance less than 30 milliliters per minute, unfractionated heparin is preferred over low molecular weight heparin, with enoxaparin dose adjustments for creatinine clearance 15–30 milliliters per minute. Obesity necessitates weight-based low molecular weight heparin dosing, especially for body mass index greater than 40 or weight greater than 150 kilograms. COVID-19. Intensive care unit patients face increased venous thromboembolism risk, prompting higher intensity prophylaxis per 2023-24 guidelines. Pharmacists play a crucial role in daily risk assessment, by evaluating venous thromboembolism and bleeding risks, recommending prophylaxis intensity and duration. They optimize dosing based on renal function, weight, and interactions, ensuring proper monitoring. Additionally, they educate nursing staff on safe administration and train providers on heparin-induced thrombocytopenia recognition and reversal, while implementing heparin-induced thrombocytopenia surveillance and developing reversal plans for emergencies.